This is the sciatic nerve. It runs from L4 through L3. This is the superior group. The inferior group arises outside the heart. All movements use the body. This is the and remove here, the vessel will be removed. This group. Here, the sand. Here's the inferior. And here's the superior. The superior. The superior. The extremities and the tarsals. The inferior is the superior. The sciatic nerve rests down the middle of the body. This is the longitudinal biceps, which crosses over and follows something. Also, biceps and the posterior small separate cells Here's the long sand and the femoral coming the external iliac. Here's the common iliac line, the internal iliac, is not the superior iliac, and here's the external iliac, becoming the femoral line. Here's the superficial surface and the external iliac. Here's the femoral, giving off the lateral surface external and the medial surface external. Now the nerves, the femoral nerve, the ocular nerve, the sciatic nerve, the inferior gluteal nerve, and the superior gluteal nerve. That brings us to the end of this section on glute. In the next section, we'll look at glute. In this section, we'll look at the knee. First, we'll look at the bone, then the knee joint and the glutes, then the muscles that move it, and lastly, the vessels and nerve. Let's see the bone, starting with the feet. We saw approximately the feet in the last section. Now let's look at this one. The two smooth interior surfaces are the lateral condyle and the medial condyle. The deep notch which separates them is the intercondylar notch. Above the two condyles are the epicondyles, lateral and medial. The sharp corner of the medial is the adductor. This one is the medial supracondylar line. This one is the lateral supracondylar line. Now we have the tibia and the fibula of the fibula. The tibia and the fibula are fixed to each other firmly by two joints, the proximal and distal tibio-fibular joints. There's almost no movement of either of these joints. Let's take a look at the proximal tibia. This is the medial condyle. This is the lateral condyle. On top of the two condyles are two quite separate articular surfaces. There's a flatfoot that goes on the femur. extends between the articular surfaces is the intra-articular area. This prominent lump on the front, the tibial cubicle, is the final insertion of the quadriceps tendon. The small passage under here is for the fibula which we have. This is the head of the fibula, this is the neck. The head of the fibula is the point of attachment of the major ligament of the knee joint, the space on each side of the knee, femoral condyle and tibial condyle, is occupied by the crescent-shaped piece of cartilage, a meniscus, which we'll see shortly. The space in the middle, the intercondylar notch, is occupied by the superficial tissues. The intercondylar notch and its contents divide the knee joint into two almost separate families. It's one more further to add to the picture. The patella, or kneecap. The patella, as we'll see, is embedded within the quadriceps tendon, which comes from here, and it sits on the tibia down here. These are articulated, even with the tendon or with the central articular when it's extended. Let's see how it functions in the living body. In filling up our picture, it's quite complicated. There are several types of movements. First, the two joint components on this one. Then the ligaments, ischial movement, and the lateral movement. Then the patella and the quadriceps section on the top. Lastly, the capsule, which encloses the joint. Here we do articular surfaces of the tibia, which is meniscus, sit on top of it. Here in the meniscus, there are the flexible fibers. The lateral one is more circular, the medial one is more C-shaped. In cross section, each meniscus is thick at the outer edge and clear at the inner edge. Two ends were attached to intra-articular area. The medial ones are fine. The lateral ones close together. In addition, each meniscus is attached all the way around its edge to the bottom and below to the joint capsule. Here's one joint capsule. We'll see more on it later. The lateral meniscus is much more open. The medial one. Partly because its two ends are attached close together. Partly because of the difference in the mobility of the joint capsule around the edge. By putting these bases between femoral and tibial contact, the menisci produces even distribution of synovial fluid to nourish and lubricate the articular cartilage between our tibia. Now let's look at the two pairs of talk about the two crucial and the two compatible elements. We'll look at the cruciate first. They're the important structures which prevent forward and backward movement of the fluid on the tibia. Their name comes from the fact that they're called cross, like this. Here's the anterior cruciate ligament, seen from the front. Here's the posterior cruciate ligament, seen from behind. To get a better look at them, we'll remove the lateral condyle of the tibia. Now we can see the whole of the anterior cruciate ligament. The anterior cruciate ligament goes from here on the tibia to here on the femur, on the inner aspect of the lateral condyle. The anterior cruciate ligament prevents the femur from moving backward in relation to the tibia. Remove the anterior cruciate ligament to see it better. The posterior cruciate ligament goes from here on the femur to here on the back of the tibia. The posterior cruciate ligament stops the femur from moving forward on the tibia. By preventing backward forward movement, the cruciate ligaments ensure that the condyles of the feet stay in place as they roll on the condyles of the feet. Without them, the feet will grow up and down and will roll up and down in extension. Now let's look at the phalanges. Tibial phalanges on the lateral side. Tibial phalanges on the medial side. The tibial phalanges goes from medial to lateral. The anterior medial aspect of the tibial phalanges then behind and also in front. Inner aspect is firmly connected every region of this which is here. Now let's look at the right tibial. It goes from the lateral left condyle tibia to the shoulder tibia. The tibial collateral stands out on the side of the medial. Unlike the tibial collateral, it doesn't fit into the joint cavity. It's not attached to the meniscus. When the knee joint is extended, both the collateral ligaments are contracted. Stressed, they become less damaged. The function of the collateral ligaments is to keep the femoral and tibial condyles together, and thus to prevent the knee joint from bending from side to side, like this, or like this. In addition to the obvious knee movements, flexion and extension, it's also possible for the tibia to rotate a little on the femur, like this. This rotation can happen only when the knee is flexed. When it's extended, the tightness of the collateral ligament makes rotation impossible. The next structure we need to have in building up our picture of the knee joint is the quadriceps tendon, and along with it, the patellar. Here's the discolated quadriceps muscle, which we'll see in more detail later in this section. Here's the quadriceps tendon. The patella, which is here, is encoded within the tendon. Part of the tendon below the patella is known as the patellar ligament. On the medial side and on the lateral side, the tendon is continuous with the capsule of the knee joint. Between the quadriceps tendon and the femur is an extension of the knee joint cavity with the quadriceps bursa. It's marked with sacral membrane. This lubricated pocket enables the quadriceps tendon to slide easily on the femur. Now we'll complete our picture of the knee joint by adding the fibrous capsule if you close it. Here's the knee joint with the joint capsule intact. On the medial side, the thin capsule is continuous with the tibial collateral ligament. But on the lateral side, the capsule is separated from the tibial collateral. On the back of the joint, the capsule is thick and strong. The thickened posterior capsule prevents hyperextension of the knee. Here, we've divided the fibrous capsule to see its inner surface. It's lined on the inside with synovial membrane all the way around the joint, except at the back. At the back, as we'll see if we remove the capsule, the thin synovial membrane here passes forward around the cruciate ligaments, covering them on the front. Besides being the largest joint, the knee joint is also much the most complicated. Before we move on to the muscle, let's review what we see first. On the femur is the lateral condyle and epicondyle, medial condyle and epicondyle, the adductor tubercle, and the epicondyle.
The articulated foot or the foot as old, you will be using the arches of the foot. Now, most of the time it is difficult to remember, or actually the last the brain and the nervous system, and the foot is ignored. Ignored in the sense the foot, see, you are wearing a good dress, everything, but a very good suit you are wearing, but you are wearing a chappal, 80 rupees chappal in Newmarket footpath. And when you are young, you are botherless. And I used to tell my daughters that don't buy this, don't buy this. And one day I told my elder daughter that don't wear this. We were traveling from Bolpur to Howrah, and strap will go off. And as she stepped down in Howrah station, it got torn. Now, what does it? Now, there are multiple bones in the foot, even in the hand. When you did the superior extremity, you see the numerous small bones, and compared to the foot, the large bones are there. Similarly, the foot, you just don't get panic. You divide the foot into 3 portions, and the bones I will teaching you, I'll show you a good slide. Now, the bones of the articulated foot organization, how to draw: talus, calcaneum, middle unit, and 5 small tarsals and metatarsal bones, arches and ossification. Now, organization: talus, calcaneus, middle unit, 5 small tarsal bones, okay, and metatarsal bones, the arches and the ossification. Identify parts in living foot. Now, the sole of the foot, articulated from below: plantar fascia and aponeurosis, cutaneous nerves, plantar muscles, first, second, third, and fourth layer, long tendons and skeletal plane, peroneus longus, tibialis posterior, and anterior, lateral plantar artery, deep plantar arch, lateral plantar nerve, and medial plantar artery and nerve. Door of the foot, rearrangement of tendons, comment on vessels and nerves. Next. Kutaili. Now, this is the picture. You please ছবি তুলে নিতে পারো, বা you draw it, whatever you is convenient, because this I told you is a very conceptual. Now, this is the half of the foot. It is the posterior half. Now, I love this picture actually as an aid for beginners to the names and relative positions of the 7 tarsal bones: calcaneus, cuboid, and cuneiforms. Navicular and talus, they accompany. Accompanying design has been found useful. Right foot, dorsal aspect after. Now, this is the calcaneum, this is the talus, this is the navicular, and this is the cuboid, and these 3 are cuneiforms. It becomes easy, it becomes very easy. Okay. Now, you see, you draw a C, calcaneum, and you draw a T, that is the talus, and this is the navicular. Now, you draw a big C, big C, big C. This is N, this is T. You copy it. Okay, and this is the C, C, C. right to left or left to right. When you catch, আরে এটা যখন তোমার ট্রেতে থাকবে, না ফিমার নেবে, টিবিয়া নেবে, ডোন্ট, একটু বোল্ডলি এটা নিয়ে নেবে. That is your batch. Even previous batch I told them, but I'm telling you, this is a very, don't panic. You can see the three cuneiforms from medial to lateral, anterior to posterior is the calcaneum, this is talus, হয়ে গেল মুখস্থ. দেখলো, তাহলে আর প্যানিক হবে না. ওটা দেখেই কিন্তু আমরা যখন ছাত্র ছিলাম, when we were student, even we used to panic. বাবরে কি হবে, হ্যাঁ. But I'm telling you, this is the most easiest way to remember this. And in next after this thing, one day I will show you an easier way to remember the hand. Now you put this in your head, and three cuneiforms, the navicular, cuboid and talus. Just pass out. একটা middle row. Okay. Now একবার করে হাতে দেখো, হাতে মেরে নাও. Okay. You see, you hold it like this. Right hand, you hold it, the right foot, and the left foot. And I told you that you try to correlate the total skeleton. When you come to the hall, you see the structures, you have your book, and you just discuss within a group and see. In the dissection hall, you will be again shown the arches of the foot and the main thing, the arch is held by bones and tendons. The total architecture of the foot you have to study. And because, see, you are not knowing the skeleton, then how will you say where your muscles and tendons are passing through and where it is getting inserted, and inversion, eversion, flexion, extension of the foot. This is the basic, you can say, the skeleton you have to know. তাহলে এটা আর ভুলবে না তোমরা. ওকে, গট ইট? অ্যান্ড প্লিজ পাস ডাউন. এক এক করে চোখের দেখা দেখে নাও, তারপরে ডিসেকশন হলে এসে দেখবে. নাও ইউ ক্যান সি this is calcaneum, talus, cuboid, navicular, and this is the three cuneiforms. This is the metatarsal. Now this bone, the fifth metatarsal a person comes limping to your chamber. He comes and says, "Sir, our at a pain hocche." Then you say, "Did you this thing have you fell down or what is your profession?" You ask. The long-standing, the BSF in Bangladesh border and Leh, Ladakh, your military men and police on duty standing, and people who are working like even a sergeant working for 6 hours standing doing an operation in a team. So these people are most prone to the fracture of the base of the fifth metatarsal bone. Now you see, this is the 3 units of the foot: anterior, mid and posterior. The anterior, mid and posterior, the 3 units of the foot, and this is the talus, the body of the talus, 2/3, and neck and head. Now, the lateral aspect of the talus and the calcaneus, a probe may be passed through traversing the tarsal tunnel, which is filled with an interosseous ligament. This is lateral process, this is the calcaneofibular ligament, the peroneal trochlear, and this is the arrow you can pass through. When you are dissecting the foot, and your dissection will be shown, and also in the hall you see the dissection, put a probe through it, and correlate with your skeleton, not your skeleton, the skeleton that is hanging in the hall, and of course you can feel the muscles, the tendons, the popliteal fossa, all these semimembranous, semitendinous, gastrocnemius, these muscles which are around the knee joint. I'm just saying, from foot to knee I just jumped, but I'm telling you that you just see the descriptive part and see the muscle, because you will be given this thing on spot. Identify tendons. There's written, this is a gastrocnemius muscle, or sartorius muscle, or gracilis muscle. Okay, now this picture, the flexor hallucis longus, the tubercles and subtentaculum tali. When you see the talus, this is the subtentaculum tali. It is like a balcony, and the talus is resting on it. So it will be on the medial side. This is the great toe. So you don't hold it like this, because this is you're having the little toe. So just look at the bones. You say, you pick up. I think I want you to, for this exam, you pick up the foot and let your teacher question you. So if you remember this part, and also you divide the foot into 2 this thing, and 3 units of the foot: anterior, mid and posterior. And see, this is the subtentaculum tali, these are tubercles, and flexor hallucis longus. Flexor hallucis longus. It is in the flexion extension. Now hallucis, hallux, great toe. So it is coming. Now again, the base tells the side. This is the first metatarsal, second, third and fourth metatarsal. The medial and lateral longitudinal arches, the calcaneus is common to both. The calcaneum is common to both. This is the arch. The arch, and the idea is it is flattened. The foot is not in 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 the masonry arch. This is the arch. Now, why I'm telling you the arches of the foot? Now, I went and spoke about your shoes and this thing dress, because if you see, the most of the people are barefooted usually previously, but at least shoes and slippers and have come very cheap, and the common people, they can access to it. Previously, people used to walk barefooted in the village, in the towns, in the ship. Now, what I want to, you name one great artist who walked the world barefooted. I'm giving a hint, a male artist. He's a famous artist. Even he's walking in the streets of London in December barefooted. Russia, barefooted. Great Wall of China, barefooted. He has a beard. He was previously a signboard painter. So much hints I'm giving. Or cinemas, the big signboards, he used to draw. M.F. Hussain. And he carried a big brush whenever he used to go. He used to carry the brush. Now, he used to walk barefooted. Now, why I'm telling you? Because see, your gait depends how you're walking. Okay, your gait, how you're walking. Someone limping like this, limping like this, limping like this, limping like this. A person, a boy, a baby is born with some foot deformity. Immediately after your delivery of the baby, it might be LUCS, it might be your normal delivery. You please, when you are doing the surgery or you are assisting the surgery, or you are not doing any surgery, you are in an intern or doing your internship in a ward, but the boy, the baby is delivered. You have to look for 3-4 things. You have to look for the anal opening, if there is the anus, and the foot, if they are deformed or not, like talipes, club foot. But nowadays, with anomaly scan, many of these deformities and cleft palate of the child is born. Okay, sometimes even though the government is trying anyway to do 3 USGs, sometimes the anomaly scan is not being done or missed by the patient, or they were not advised accordingly. So these anomalies actually is not detected. So again, the third ultrasound, the detection to some extent, but 20 to 22 weeks, you have to detect any deformity. If you have shortage, the limbs are short, one amelia, there's only one thing is developed. Now the arch is not developed by slowly this thing, but the bones are there, and see if it is a talipes equinus or talipes vera or talipes valgus. That you see when you see the baby like this. You put a torch, see the cleft, see if it's a cleft lip. If any small deformity, a ear is not there or something, don't be casual, because these things, even you see anorectal malformation, that doesn't come out in this thing. Your all deformities or congenital malformations, they don't come. They are depicted in the ultrasonography. But this you have to keep in mind, that the foot deformities are there. and can happen. Okay. Now, articulated foot, you see the skeletal picture. That was just a introduction with to give you an idea. The same thing you will be seeing your articulated foot, you will be seeing in the video also. Now, functions of the arches of the foot. The proportional distribution of body weight, flexible lever for forward propulsion, protection to plantar vessels and nerves, acts as shock absorbers and during jumping and jolting. So, when you dissect or you sit down and just open your, তুমি নিজের ফুটটা দেখবে, আর এটা কি এত মুখে ফেশিয়াল, এত মানে আইব্রোজ এগুলো সব করা হচ্ছে, ক্রিম লাগানো হচ্ছে, কিন্তু ফুটটা নেগলেক্টেড থাকে। হ্যাঁ, so you do your own pedicure. You even in college, you take a small bowl and put your warm water and you just put on the music and you just play like this, put shampoo and see, because see, these things also count, because if your pain or your foot infections, the more it is a very you have to take care of the foot. मुंह में ऐसे साबुन लगा के ऐसे ऐसे कर दो, लेकिन you don't neglect even the male members. I'm telling you, take care of your foot, because once you are affected with some problem, it will carry on with you. ठीक है? Now, one thing is medial longitudinal arch, lateral longitudinal arch, and transverse arch. Okay. Now, the medial longitudinal arch, bones involved: calcaneum, talus, navicular, 3 cuneiforms, and metatarsal. First, second, and third. Summit, the trochlear surface of the talus. Anterior pillar, heads of the metatarsal. Posterior pillar, medial tubercle of the calcaneum. This is. And keystone, head of talus. Key joint, key ligament, spring ligament. And more bones and joints more resilient. Now, this is a medial longitudinal arch. You see the bones, and these are the ligaments. These are the ligaments. Because you get you slip, you get this thing, your ligamental tear. It is very painful. If you fracture of any bone is not so much painful. But if there is ligament tear, or you're walking or running or playing football or whatever, dancing or whatever, suddenly you slip and you cannot get up. You have now lateral longitudinal arch, bones calcaneum, cuboid, metatarsal, 4th and 5th. Summit, superior surface of calcaneum. This is the superior surface of the calcaneum. Anterior pillar, heads of metatarsal, anterior pillar, the heads of the metatarsal. Posterior pillar, lateral tubercle of the calcaneum. Keystone, calcano-cuboid joint. Key joint is the calcano-cuboid joint. Key ligament, plantar ligament. Less bones and joints more rigid. Now, actually these ligaments, these arches like this. So it has to be supported. And these ligaments and tendons and muscles, that is supporting it. And it has a cushioning effect, the whole foot plantar aspect. When you dissect, you will be seeing that your fat, then aponeurosis, see any foreign body like a needle or your thorns, especially 2 thorns are dangerous. That is your baler kata. Bale, you know, bale. Now, bale has a long thorn, and some bushes, there are some thorns in the, I'm talking about rural areas. And you won't be finding it in Park Street. Even if you are drunk in New Year Eve, Calcutta consumed 2,200 crores liquor on Christmas Day and your this thing. But you can walk even barefoot, like MF Hussain. You can walk, there won't be any thorns, but there can be a glass bottles, this thing, piece going into your soul. And this is, today you have to prescribe for an ultrasound, USG of the foot, and X-ray of the foot or radiography of the foot. So you have to take it out. Now, it has become easy for the surgeons that you can take it through C-arm, this thing in the orthopedics they are using, C-arm X-ray, radiology. Now, but a person like in my OT, I don't have a C-arm. And previously, without an X-ray. Now, but you must keep in mind that you order not, there's a big, this thing in, at least Bengal, I'm telling you. Headache, the husband is prescribing CT scan, skull, head. No, he's not a doctor. अरे दारू पी के उसको वाइफ को पिटाते हैं तो वो ऐसे करते रहते हैं, डोमेस्टिक वायलेंस. ओके, चल डॉक्टर नहीं जाची, and goes and writes self. Who's the doctor who prescribed self? Doctor, referred by doctor. The radiological center says that referred by doctor, self. And the CT scan brain comes normal. Just a joke I've told you. That one thing I tell you, that you must, for any pathological condition, even if there is your cyst in the sole, it implanted dermoid. Implanted dermoid means a small thorn can pierce and through the sole and lodge. This is small. You have ignored it. Patient suddenly develops into a small dermoid cyst, implanted. The cells has been implanted when it was pushed with the foreign body into the sole. These things are the relevations of the thing, and the arch of the foot. You will see one mother, when the child is walking, they don't see it in that form. But when he starts walking, then there's just 2 years, 3 years, or 4 years, then there's a flat foot. It means in the now in Bengal especially, Lakshmi Puja. So this Alpona, they draw 2 foot of Mother Lakshmi. Imprint of the foot of Mother Lakshmi, Goddess Lakshmi. Now similarly, when you feel bit this thing, you want to be very accurate, you can just put some color and take an impression on your this thing. Plus clinically, if you see, you can see the arch is lost. Even in adult cases, even it was ignored. Now if the arch, if the medial component, the lateral component, how much, then special shoes are there. You have to order for special shoes. So they will make these shoes and put wedge. See, if it is a see when this walking now walking like this. That means this arch is lost. So you have to elevate it. Now the medial portion is this thing, it's become flat like this. So you have to put a sole, the shoe's sole, and it will be like this, a wedge. They are specially made, and a rubber component is put in, and that will be delivered to you. But nowadays, if you go to the store, means in not Crocs store or Khadim or Batas, but you have to go for these orthopedic appliances store. They are having this silicon based inner sole, or you are having a problem with the heel, then there's a silicon based, they give you, paste it in the this with the sticker, it is like those tapes, you put it in under the thing, and that is maintained. But if it is severe flat foot, then you have to order your shoes, especially those who are dealing in orthopedics appliances, you have to order. Okay, now this actually, a patient is complaining of heel pain or something like that, you try to examine her, you let her stand, salwar sari jo bhi hai thoda uthao itna tak, and you see the thing. Make her stand on the table or stand on the in a height, so you can measure, you can see. Clinically you see. You see one thing, when you open a dressing of an operation, it is smelling, pus is coming out. So always don't put a handkerchief like this. You try to smell. See, you are removing an operation drain. Exudate is coming. You put a drain, you are seeing the peritoneal fluid or color is a bit different. It was an infected case, or a person was, her intestine or his intestine was accidentally was punctured or stabbed. Then you have repaired, you have repaired, a very good surgery was done. So if that is on the third day, you will go for a check, the dressing, change the dressing, then you try to smell. Because still at this age, I do it. You have to make things, some things in clinical examination, your habit. So similarly, don't neglect, oh, painkiller de diya, aap aise karo, or you just don't talk. Most of the doctors don't talk nowadays. They are not talking, complaining, there is no sympathy, there is no empathy. But you just say, okay, ma, bolun, oh, tomar mashi ma. Okay. You speak in the local dialect. Kareena Kapoor won't be by that time she'll be old, when you become a great doctor in Bombay. But you have to see for flat foot, see if there is any cyst, see if there anything that's in the sole, there is some cord, and wear a comfortable shoe. I'm telling you people, you wear a comfortable shoe and a branded shoe. It is your choice. But nowadays, what is the trend is that don't try to do this. Okay. Now, where we are going now next is this, the lateral longitudinal arch. And you see the ligaments, see how it is holding. This is the plantar aponeurosis. Plantar aponeurosis, this fat. See, this is the plantar aponeurosis. Okay. Now, there will be fat cushioning. So, if your nail pricks up. So, in this campus, the last 4 years, there were lots of nails in the roads, and so it is still lying. They lie. Even tires get punctured. So like that, it goes shoot. It goes in the sole. So you have to do an X-ray. You have to do an USG. USG is a wonderful tool, and because if the now this is the bony component I'm saying. Now this thickness is the over here the plantar fascia, plantar aponeurosis, and this is layer of fat. Now after your the foreign body location, you try to don't just make a big incision or something like that. Actually, usually what happens, if it goes through the sole, then it has a passage. But sometimes with pressure, it might go inside. It move, but it doesn't say it will move. Some people fear it's moving, it will moving. No, but it shifts. That's some shift because of the compression and this thing that shift. But one key thing is that the hole through which it's gone, you first go make a small incision here, and then slowly you put a probe or a hemostatic forceps and see your infected material. That might be pus, it might be this thing. It is different from the neighboring tissue fluid. So you can locate and take it out. Don't mess up. But actually, my surgery, actually, I don't like bleed. You're cutting piles, you're doing hysterectomies. Bleed korche, I don't. Plane by plane, if you have an idea of tissue planes, even if you are not, did not read anatomy as such, but you have to go back to anatomy. You read, before a big surgery, you read books. You read. I still read. And you audit. Parashunate kotota korcho, you have to audit yourself. How much you are doing. Right. Don't fear. Because exams are coming, you become, everyone suffers from fear psychosis. Eta korbo. No. Ekbare fixed. Physiology, biochemistry, anatomy. Physiology, biochemistry, anatomy. You are coming to college, study anatomy. This dissections and all will be there on foot, and your sciatic down. Now, transverse arch of the foot. Each foot presents half arch. Complete arch is found when both feet are approximated. So, each foot is forming half of the arch. Now, when you, like this, you stand like this, then that forms the complete arch, the transverse arch. Now, bones, cuboid, cuneiform 3 and base of the metatarsal. So, you see the bones that which I I drew a picture on the half of the foot, then again 3 components of the foot according to the small bones and large bones, and also the metatarsal bones. Now pillars, bases of the fifth metatarsal bones. See, it is like this. It is like this, like this. See the base when it puts in my hand like this. Then the base of the fifth metatarsal is pillars. You go actually everywhere you see it. Especially have you gone by car to Calcutta? You see in Vedia you're going towards Guskora. There's the bridge which is traversing the river Ajay. You can see the arches. You can see the pillars. It is that concept is in the foot. Now you can see the transverse arch. It is cut like this. So you can see the arch. This is the metatarsal. This is the lower end of the tibia. This is the medial malleolus. This is the lateral malleolus by fibula, contributed by fibula. This is the calcaneus. Now, scaphoid, internal sphenoid bone, talus, cuboid, metatarsal, phalanges. Here, maintenance of the arch. Now, shape of bones. The shape of bones. Intersegmental ties. The 3 segments, that's the intersegmental ties with the ligaments and tie beam. The flexor hallucis longus. The tendon, when you dissect the leg, you will see the flexor hallucis longus. At the base of the fifth. Now you see this is the tie beam and this is the suspension, the peroneus longus, this is the suspension. Now the peroneus longus, you'll be having these muscles in the fibula and also in the tibia. You have to, when you dissect, this week there will be dissection, and also you correlate the maintenance of the arch. It can be a short note, it can be a small question of 2 marks or 3 marks or 5 marks. Maintenance of medial longitudinal arch, shape of bones, wedge shift, intersegmental tie, spring ligament, tie beam, plantar aponeurosis, flexor digitorum longus, flexor digitorum brevis, flexor hallucis longus, flexor hallucis brevis, abductor hallucis. Now, these you have to remember. It can be a long question, can be on the arches of the foot. So, you just remember, every book is having it. But that first picture, only Grant's anatomy is having. If you want to go, you can just Grant's anatomy and you search in the net, you download and see this. But you don't want to spend time, then I've drawn and you can take it. Here, see. See, maintenance of the, this is the tibialis posterior. This is the tibialis posterior, the tibialis anterior, and this is flexor digitorum longus, and this is flexor hallucis longus. This. Now, maintenance of lateral longitudinal arch, shape of the bones by shaped intersegmental ties, long and short plantar ligaments, tie beams, plantar aponeurosis, flexor digitorum brevis, flexor digitorum longus, flexor digitorum suspension, peroneus brevis, and tarsals. These are small muscles here. You can see the tibial is anterior and digitorum longus, extensor digitorum longus, extensor digitorum hallucis longus, and this is the peroneus brevis, peroneus longus. This is the calcaneum and lateral malleolus here. Now, flatfoot is pes planus and metatarsalgia, pain in metatarsal region of the foot radiating towards the toe. So, metatarsalgia and the pain in the metatarsal region of the foot radiating towards the toes.